Thank you all for coming today. We'll start now the grand round for today. Our speaker will be Dr. Dania Bamefleh. Dr. Dania, she is a consultant ophthalmologist, member of Glaucoma division at King Khalid Eye Specialist Hospital. She is going to talk about very important topic that we counter every day in the clinic, in the emergency, and even in the floor. It is about the management of glaucoma or high pressure sometimes after vitreoretinal surgery. Welcome, Dr. Dania. You can start.
Assalamu alaikum, Doctor. Can you hear my voice?
Yes, very clear.
Great. Good afternoon, everyone. It's such an honor to present today this subject that I find of interest, and as Dr. Rayan was mentioning, it's something we're being encountered on a daily basis. So without further ado, our topic is today about management of glaucoma following vitreoretinal procedures. I have no financial interest in the material presented at this presentation. The contents of the lecture is going to be to highlight the importance of this burden and this subject, a brief introduction, and therefore we will go through a management of glaucoma following each and various vitreoretinal procedures, starting by vitrectomy, scleral buckle, and then minor procedures like PRP, anti-VEGF injections, triamcinolone injections, silicone oil-induced glaucoma, and management of intravitreal gas. So the importance of this subject, because the surgical management of retinal disorders, including Paris plana, scleral buckle procedures, and intravitreal injections of gas, silicone oil, can lead to a short-term elevation in intraocular pressure and ultimately a long-term burden and glaucomatous damage if not treated in a timely manner. Glaucoma in these cases tends to be refractory to the conventional therapies, and this talk perhaps will highlight treatment strategies for each of those. Glaucoma is a leading cause of irreversible vision loss, and it's related to several risk factors, including age, race, family history, and central corneal thickness. Of none of these we could control. The only modifiable risk factor is the intraocular pressure. So Paris plana vitrectomy is the third most common ophthalmic procedure following cataract and excimer laser with a good safety profile. However, it's not free of complication. So glaucoma following the PPV, the incidence back in the era between 1970s to 1980s, it was ranging between 20 up to 60% of the time following the surgery. However, an advancement of the surgeries, the materials and the intervention perhaps, it's estimated to drop to 15 to 20 in a study done in 2006. Another study in 2012 observed to reach 11.6. 15 of those concurrent with cataract versus phakic eyes, which was only 1.4. A most recent study I could find is in 2014, and it showed that the percentage or the incidence of the elevated pressure was 19.2 in uncomplicated vitrectomy procedures, in comparison with 4.5 in fellow eyes. So they find that the risk factors for this to happen are combining the vitrectomy with scleral buckle, or the use of endo-photocoagulation concurrently, or lensectomy, or the formation of a fibrinous reaction post-operatively. Or even if the pathology was proliferative vitreoretinopathy, it's shown to be a risk factor rather than operating vitrectomy for a macular hole, for instance. The pathophysiology, it's quite not very clear and there is area of ambiguity. However, the vast majority of the cases they found to be of open pathology, and their hypothesis it's either due to the gas expansion, inflammation, or silicone oil induced without the pupillary block, or steroid response, or blood-related mechanism. The angle closure is only about 20% of those cases, and the theory of pupillary block can be due to the gas-induced silicone oil, fibrin, IOL, ciliary body edema, or iridocorneal apposition. Management, the vast majority of patients without a pre-existing glaucoma, the good news that their optic disc can usually tolerate the transient rise in IOP with no evidence of the overall effect of the visual function. If the therapy is needed to control the IOP, most cases they do well with managing medically of anti-glaucoma in the form of aqueous suppressants or by tapping the gas in cases of overfill of posterior segment. The suggestive surgical intervention, at the beginning, it's used in a failure of maximum tolerated medical management. At the beginning, they started to do a trap combined with mitomycin. However, they found that the scarring was a significant point, and that they had to do something more to control the pressure. So glaucoma drainage devices came to the rescue in 2013. They did a study, in fact, on using the Bervolt implant, and they placed some in the anterior chamber, and they placed the other arm in the pars plana placement. And that they found after 2 years of follow-up that the mean average decrease of IOP is quite equal, like 57% in pars plana group and 60% in the anterior chamber, with very limited complications in both arms. So moving to the second procedure done by the vitreoretinal surgeons is the scleral buckle. The incidence of occurrence of glaucoma, it's glaucoma, like a diagnosis of angle closure glaucoma, it's 1.4 to 4.4. However, the incidence of the shallowness without the glaucoma, it can be more prominent, 14 up to 50% of those. The risk factors were found to be a pre-existing narrow angles, or the use of encircling band rather than segments, or placement of the band anterior to the equator, high myopes, elderly or old age group, or the development of a post-operative ciliochoroidal detachment. The pathophysiology behind the scleral buckle causing the glaucoma, they hypothesize that it's a result of impairment of the venous drainage through the vortex veins by the buckle, leading to congestion and swelling of the ciliary body. This edematous ciliary body is displaced anteriorly about the scleral spur, and therefore narrowing and causing a lens iris diaphragm moving forward. Suggestive management plans. In most and past majority of the cases, secondary glaucoma usually resolves spontaneously within several weeks. Giving medication is also advisable, like in the form of cycloplegia to relax the ciliary body, steroids to reduce the inflammation and the swelling, aqueous suppressants in cases of high intraocular pressure. Laser iridoplasty is also it's a good tool actually, might be beneficial in cases refractory to medical treatment by reopening the angle and further deepening of the anterior chamber. Laser iridotomy, however, is rarely helpful because the mechanism usually behind the scleral buckle, it's not pupillary block. Surgical intervention, again, the trap, it's quite technically difficult along with the buckle, and the fibrosis and scarring will stop it from functioning shortly. In 1994, they found that the aqueous tube shunt achieved better IOP control, and they reached an IOP final between 6 to 21 millimeters of mercury in 85% of the cases that underwent the tube shunt procedure in a period of 1.5 years up to 4 years post-operatively. The way that they did it was actually to utilize the capsule that was formed around the scleral buccal. They created an opening, they inserted the tube there without a plate, and then closing it, creating a fistula in order to achieve reach inside the anterior chamber, and covering that with a scleral and patch, and they had a quite successful outcome. 6 years after that method was described, Bervelt implant was started to get more involved in those cases, and the two surface areas of Bervelt plates were actually utilized, and their hypothesis was also to actually remove the capsule around the scleral buccal, and therefore you will have a more larger reservoir for the aqueous drainage system. And all patients, they achieved actually successful IOP control during the follow-up period, again between 1.5 years and up to more than 4 years, with no reported complications. Now we'll move to minor procedures that could also cause glaucoma, like PRP. The incidence of rise of pressure following PRP, it's quite common, and it can range between 32% up to 94% of the time, and the rise can be more than or equal to 6 millimeters of mercury on top of the pre-treatment of the laser. The IOP spikes usually occurs immediately after the PRP, and they find it like the peak will be achieved in vast majority within 2 hours after the laser. The risk factors were not well studied, unfortunately. However, they hypothesized that lowering the laser energy level may be associated with a decreased incidence of severity of IOP elevation following the laser. And neither the age nor the type of diabetes influenced the development of the high IOP. The pathophysiology, it can be open or closed. Open mechanism is suggestive that aqueous outflow blocked due to compression of episcleral veins induced by the contact lens used to deliver the laser, and movements of fluid from choroid into the vitreous secondary to the breakdown of the blood-retinal barrier. Decrease of also uveoscleral outflow from the congestion of the ciliary body, or direct damage to the short ciliary nerves caused by the laser damage, and therefore it would release prostaglandin and decrease the overall tone of the ciliary body. It can also be a closed angle due to swelling of the body of the ciliary body, or movements of fluid from choroid into the vitreous secondary to weakening of the blood-retinal barrier, which can lead to displacement, forward movement of the lens iris diaphragm. Management. IOP elevation is usually transient, and it would resolve within a month. And they attempted to do a pre-treatment of using aqueous suppressant in the form of apracolonidine 0.5 to reduce the incidence of high IOP post-treatment, and they compare it with a placebo, but they did not find much of a statistically significant benefit. The IOP elevation following the PRP can usually be managed simply medically by topical medication, cycloplegia, aqueous suppressants. Anti-VEGF the incidence of IOP elevation following the injections can range between 3.4 up to 6% and appears to be related to the number and the frequency of injections. The risk factors, they find that bevacizumab raises the pressure in 9.9% in comparison with administering the ranibizumab 3.1, as well as higher prevalence in patients with a pre-existing disease compared with eyes that have no underlying glaucoma. Another factor appears to be related to the frequencies of anti-VEGF. The more that the eye gets, the higher the chance or the likelihood of having glaucoma. The pathophysiology is not quite clear. However, like the immediate rise, it could be related to the volume expansion that's delivered inside the vitreous cavity, or it can be that the drug itself, it obstructs the aqueous outflow via the trabecular meshwork and the uveoscleral pathway or the Schlimm's canal. The management, as the half-life of intravitreal ranibizumab is approximately 3 days, the elevated IOP seen following the intravitreal injection is usually transient. Reducing the frequency is a suggestive way, and keeping it to PRN rather than like injecting it more frequent. Triamcinolone injection. The incidence, it's quite significant. It can reach up to 40% of eyes administered. They can have the glaucoma that is greater than 24 millimeters mercury at 6 months after delivering the 4 milligrams. Risk factors were pre-existing primary open angle, or the patient had an ocular hypertension, positive family history of glaucoma, connective tissue diseases, type 1 diabetes, and high myopes. And also they say about the age, it's bimodal, like 6 years of age or greater than 60. The pathophysiology, it can be three mechanisms, either combined or each one as a solo mechanism. Induced physical mechanical changes in the microstructural level of the trabecular meshwork, thus impending outflow of aqueous humor, or increased deposition of substances in the trabecular meshwork, which could reduce the outflow, decreased in the breakdown and the phagocytosis of meshwork cells. So all of which, the three of them, they impaired the function of trabecular meshwork, and therefore you will have the high IOP. The management, it can be following intravitreal injection, should be monitored regularly. And there was a study that was mentioning that checking the pressure day 1, week 1, and monthly up to 6 months, and therefore to avoid the burden of glaucoma. Initial management includes discontinuing the steroid also injection or counseling with a glaucoma specialist prior to administering the disease. There was a study that suggested that triamcinolone induces IOP could last up to 9 months following the injection. Treatment with anti-glaucoma medication is usually sufficient in controlling pressure, and IOP returns to baseline, and glaucoma medication can be discontinued after like 6 to 9 months after the initiation of injection. Agrawal family, they found that the medical management was doing wonders. However, they had to do TRAP in 2% of the cases, and that were not responding whatsoever after receiving the injection to all the medical management. And they did standard TRAP and appears to be working, as they mentioned in their paper. And they had to do a TRAP with vitrectomy to remove in one patient the triamcinolone alone, not only TRAP alone, to achieve successful control of pressure. Glaucoma following the use of silicone oil. So the incidence of the silicone oil induced, it's variable. It's ranging between 2.2 at 6 months and up to 56 at 8 months following the surgery. And with more recent studies, they found that lower rates are being estimated, likely because of the improvement of surgical techniques and the materials utilized. Higher viscosity silicone oil have been noted to result in fewer emulsified silicone droplets in the anterior chamber and lower the risk of glaucoma. Risk factors for having a silicone-induced high IOP. It can be pre-existing glaucoma in that eye or history of diabetes, aphakia, and care must be taken by the VR surgeon to avoid overfilling the eye with silicone oil, as this may produces secondary glaucoma. The pathophysiology of rise of IOP, it can be explained like early and late. The early rise, it can be due to pupillary block, inflammation, pre-existing glaucoma. Migration of silicone oil into the anterior chamber could also be one of the etiologies. Late onset, it's usually due to infiltration of trabecular meshwork by the small, teeny tiny bubbles of silicone, or the chronic inflammation, synechial closure, rubiosis iridis in some cases, migration of emulsified silicone bubble, or non-emulsified, the large ones, into the anterior chamber, or it can be idiopathic. So suggestive management treatment of silicone oil associated glaucoma depends largely on the clinical presentation and the mechanism of IOP elevation. Management may include topical medication alone or in conjunction with a surgical or a laser intervention. Topical medication therapy, including cycloplegia, steroids, or aqueous suppressants in the form of beta blocker, prostaglandin, have shown to result in a successful control of pressure in 30 up to 78% of patients at the study done in the late 90s. Prophylactic peripheral iridectomy inferiorly have been shown to lower also the incidence of pupillary block caused by floating silicone oil. However, peripheral iridectomies must be monitored because they can be closed actually in 11 or between 11 and 32% of the time, and they will need to be reopened, or you need to create new iridotomies to prevent the development of pupillary block. Transscleral cytophotocoagulation may be a good option when the risks of redetachment addressed by the VR surgeon and the removal of silicone is unacceptable, or the eyes with poor visual potential. Early removal of silicone may result an improvement in IOP control by reversing all of these mechanisms or the mechanical trabecular blockage. However, the silicone oil removal must be weighed again by the risk of retinal detachment. And there was only one study, single study, that said that 93, I was fascinated by the number, 0.4% of the patient, they had normalized IOP after removal of silicone oil tamponade without further glaucoma management. A persistent rise of IOP after the silicone removal is thought to be due to inflammation, edema of the trabecular meshwork, as well as the obstruction of meshwork by small oil droplets. Glaucoma surgery and drainage devices may be considered in patients with refractory glaucoma, as well as patients with complete synechial closure, since silicone oil removal alone is unlikely to be beneficial. Glaucoma surgery and drainage devices may be considered in patients with refractory glaucoma, as well as patients with complete synechial closure, since silicone oil removal alone is highly unlikely to be beneficial for those cases in a study done in 2005. The standard filtration procedure may be technically difficult due to the scarring of the conjunctiva from prior surgeries and manipulation, and associated with a poor prognosis and increase the risk of complications. So drainage devices like Ahmed, for example, glaucoma valve to be placed inferiorly, shown to be having a good success rate in 6 months. There was a study that was done in 2005 that showed 85% good control of pressure post-operatively, and 76 at 1 year of following implant. Lastly, glaucoma following intravitreal gas. The incidence, it depends on the type of gas, the SF6 or the C3F8 injection. They find that the SF6 is ranging between 6.1 to 67% risks of having a high IOP versus the C3F8 18 up to 59% of the time. The higher incidence associated with the C3F8 is thought to be related to its greater maximal volume expansion in comparison with the SF6, as well as the longer intraocular longevity of the C3F8. The risk factors were higher concentration of the expansile gas used, the use of C3F8 rather than others in elderly people, or intraocular or intraoperative use of photocoagulation, concurrent lensectomy, placement of scleral buccal, circumferential scleral buccal, fibrinous anterior chamber reaction post-operatively. The pathophysiology can be open or closed. The open mechanism of a gas suggests if it's due to the expansion of the gas bubble exceeding the rate of outflow of intraocular fluid, or when the intraocular gas volume causes posterior chamber pressure building up without causing angle closure. Or it can be due to a closed angle resulting from the anterior displacement of the lens iris diaphragm, causing iridocorneal apposition as a result of either pupillary block or non-pupillary block mechanisms. The management, intraocular pressure should be assisted using Goldman, and it's proven in this study that using Goldman or Perkins tonometer is superior on using because it was done in 90s, so they compare it with the Pneumo and the Schiots, and they find that the Goldman applanation was superior. Patient education is very essential part in the management, because you have to give him the red flags, explain if he has any symptoms of high intraocular pressure to seek help ASAP. The importance of maintaining a prone position must be emphasized by the vitreoretinal surgeon to prevent anterior displacement of the lens iris diaphragm. In addition, that the patient should be strictly instructed to stop the air travel or the going to up hills or mountains because of the atmospheric changes that can cause further damage to the eye. Elevation of IOP usually occurs within first 24 hours, and mild elevation in IOP frequently responded well to topical aqueous suppressants or oral like systemic carbonic anhydrase within 1 to 3 days post-operatively. If the IOP rise is very refractory or severe, it may be necessary to aspirate a portion of the intraocular gas to normalize the IOP. Laser iridotomies is beneficial in cases of pupillary block, not in all cases. And glaucoma drainage implant may be a better surgical option compared to traditional filtering surgery if there is extensive or conjunctival scarring. Okay, so to conclude, vitreoretinal surgery is a known risk factor for IOP elevation and progressive glaucomatous damage, and therefore clinicians must closely monitor these patients post-operatively. Depending on the procedure performed, patients may respond to medical therapy, but laser or glaucoma surgery may be required in some of those cases. The glaucoma drainage devices are important treatment modality for these patients, although the surgical technique may need to be modified. The prompt diagnosis and treatment of elevated IOP after vitreoretinal procedure can prevent further ocular damage and improve the overall patient outcomes. These are my references. Thank you so much for your attention. And I hope that Rian and I are ready to answer any inquiries.
Thank you, Dr. Dania, for this excellent comprehensive overview of this important subject for us and for our colleague in vitreoretinal surgery. I guess we have time. We can open the area for any question from the audience. Okay. And I would like to highlight some point that you mentioned about the patient with both silicone oil, BBV and silicone oil. Maybe some of our colleagues in vitreoretinal, they are not agree on this, but I feel it is more safer to do the surgical BI in pseudophakic patient. Because we all agree that BI is important in all phakic patient, but sometimes pseudophakic patient, you don't know what happened in the cataract surgery, so patients will come with silicone oil and people will block later on. This is one point. Another idea to solve sometimes, if the patient going to have lens removal with BBV, to use a CTR, because this CTR will make the zenules stretch, so the silicone oil, even if there is some injury to the zenule, will not be able to come. One important thing also, I guess, if the patient had recent surgery with silicone oil and the pressure is very high, like the first post-op day or second, one idea is to use temporary measure like Diamox or mannitol. And we all know mannitol is an osmotic agent and it works on to take the fluid from the vitreous to the intravascular compartment. This is what we know. So most of us, they state that why we give mannitol while there is no vitreous gel that the patient had silicone oil. But there is a study that have been done by Takari 2017. They compared the patient with silicone oil and patient with normal eye, and they found the mannitol actually work more on patient with silicone oil. So I guess this is one of the mechanism that also can help, especially in the first few days post-op.
So may I comment on VI on pseudophakic patients?
Yes, Suleiman.
So it is quite rare that you get papillary block in pseudophakic patients, especially if the capsule and the iris lens, the IOL diaphragm is intact. So the thing is, what we do if we see migration of air into the AC during fluid air exchange, then we strongly consider a PI in pseudophakic patients. Otherwise, if no air comes anteriorly, then we really don't do it. It comes down to the number needed to treat in order to prevent one rare incidence of biliary plaque. So this is my point of view to this suggestion. Thank you.
Okay. Thanks, Dr. Dania, for your time and presentation. Thank you for all the audience for attendance today. We hope to see you again. Thank you all.
Thank you.